So the title of my poster is Lone Atrial Fibrillation in the Young, Perhaps Not So Lone. So lone atrial fibrillation is generally defined as atrial fibrillation in the setting of a structurally and functionally normal heart. While atrial fibrillation is very common in adults, it is quite rare in the pediatric population. Now, there are reports in adults of other forms of SVT, such as ectopic atrial tachycardia, orthodromic reentrant tachycardia, and AV nodal reentrant tachycardia that can be a trigger for atrial fibrillation, but this has not been demonstrated in pediatrics. So we sought to determine the incidence of other forms of SVT in lone atrial fibrillation in the pediatric population. So we reviewed the data from 3 pediatric arrhythmia centers and included all patients under 21 years of age who had an episode of lone atrial fibrillation and who underwent electrophysiology testing and invasive testing. We found 18 patients. Interestingly, the majority were adolescent males who were overweight. 60% were overweight or obese. And 83%, or 15 of them, were males. 67%, or 2/3, converted spontaneously to sinus rhythm and never needed cardioversion. So the most important finding in our study is that 7, or 39%, had an additional form of SVT that could have been a trigger for their atrial fibrillation. There were 5 patients with AV nodal reentrant tachycardia, or AVNRT, and 2 patients with concealed accessory pathways and inducible orthodromic reentrant tachycardia. And those patients were ablated. Of the 7 patients who had inducible SVT, at a mean follow-up of 1.7 years, none of those patients had a recurrent episode of Afib. Of the 11 patients who had no inducible SVT, 2 patients had recurrent Afib. So in general, the conclusions from our paper were that a large percentage, 39% of patients who were studied with lone Afib, had an additional form of SVT, either AVNRT or concealed accessory pathway. The majority of the patients were overweight adolescent males. And from this, we would conclude that one can consider doing an EP study as part of the workup of lone Afib in the young. I just want to point out that while adults undergo ablation for Afib with pulmonary vein isolation, this is not something we would consider and be a standard treatment for children. But perhaps searching for an additional form of SVT, such as a concealed pathway or AV nodal reentrant tachycardia, could be part of the diagnosis and treatment of lone Afib in children.